I would like to welcome you to this TBIO 572 video on the topic of cervical cancer. Now, to start out, I will briefly consider the history of this condition as summarized on the next slide. Running horizontally across the center here, you can see a timeline for the major developments in the diagnosis and treatment of cervical cancer. The first of these was in the year 1905, when the surgical procedure of radical hysterectomy was devised to remove cancerous tissue and thereby spare the patient's life, assuming that the cancer had not already spread. Then, in 1928, Dr. George Papanicolaou developed the Pap test to identify individuals at risk. Now, up until this time, cervical cancer ranked as the #1 cause of cancer mortality in women in the United States. But with the widespread adoption of this test, in the 1940s both the incidence and mortality rates decreased dramatically, as indicated by the chart at the top. More recently, in the late 1990s, a new improved version of this procedure, termed liquid-based Pap test, was approved and came into widespread use. To date, the mortality rate of cervical cancer has been reduced from #1 to #8, below that of leukemias or lymphomas. The next major advancement occurred in 1983 and 4, when researchers found that cervical cancer was predominantly caused by infection with certain types of human papillomavirus, or HPV. In this regard, cervical cancer joins a small group of viral-induced malignancies, such as Burkitt's lymphoma and some types of liver cancers. This discovery has also led to the development of vaccines that will hopefully prevent cervical cancer in the future. This chronology dramatically demonstrates the importance of both research and early detection in the successful treatment of cancer. Now, to understand the nature of cervical cancer, you must first appreciate the gross anatomy of the cervix. As shown in this slide, the cervix represents the lower cylindrical portion of the uterus. Now, the anterior region of the cervix consists mainly of collagenous connective tissue with a few scattered smooth muscle cells. In contrast, the rest of the uterus contains a thick layer of smooth muscle called the myometrium. Also note in this figure that the cervix consists of two portions, the exocervix that bulges out into the vagina and the endocervix that is more internal and surrounds the cervical canal. Now, these two portions of the cervix are lined by different types of epithelium. Most of the exocervix is lined by a stratified squamous epithelium that also lines the rest of the vagina, while most of the endocervix is lined by a simple columnar epithelium that is continuous with the rest of the uterine cavity. Now, it is important to note that the junction between these two types of epithelia occurs very abruptly and is termed the squamous columnar junction. The yellow arrow on this slide shows the location of the squamous columnar junction. As you can see below this region, the epithelium is stratified squamous. That is, it is multi-layered and the free surface consists of flattened squames. This epithelium is non-keratinized, which means that the cells remain alive and retain their nuclei all the way to the free surface. And above the junction, the epithelium is simple columnar. That is, it is one cell layer thick and the individual cells have a columnar shape, although it is difficult to observe this at this particular magnification. It is important to note that the location of this junction does not remain static, but rather can move around depending upon the individual's age, menstrual cycle, and other factors. Now, the region in which the junction moves about is termed the transformation zone and is indicated by the dark area in the figure on the right. As you can see, the transformation zone is a region on the exocervix that immediately surrounds the external os, or opening. Now, this is important because the transformation zone is the region of the cervix where most HPV infections and carcinomas occur. Presumably, the stem cells that reside in this location are particularly susceptible to viral infection. And this leads me to the next topic of HPV infection. As I indicated before, in the early 1980s, researchers found that infection by certain strains of HPV is the causative agent of cervical cancer. Now, when one of the basal cells in the cervical epithelium becomes infected with HPV, two things may happen. As shown in the center here, the first is a productive infection in which the virus makes more copies of itself. And in the second thing, shown on the right here, is that the virus may incorporate itself into the genome of the host cells, causing them to undergo a transformation that can lead to cancer. Now, I would like to describe both of these events, starting with the productive infection, shown in the middle here. The virus takes over the machinery of the cell and causes the production of more virus particles. In the process, it induces the infected cells to form a condyloma, or a wart-like structure on the cervix. Indeed, the term papilloma from human papillomavirus means wart. Now, normally, cervical condylomas are not grossly visible. However, if the cervix is first treated with acetic acid, then they appear as white macular lesions as shown here. As I indicated before, these are sites of active HPV infections and most often occur in the transformation zone of the exocervix. This slide shows the histological appearance of a condyloma. Now, for comparison's sake, the panel on the left shows a normal cervical epithelium, while the panel on the right shows that of a condyloma that is undergoing an active HPV infection. Clearly, there are obvious differences. The normal cervical epithelium on the left consists of a basal layer of cells that are cuboidal in shape, and above that the epithelium has formed multiple layers of flattened squames up to the free surface, which in this example is marked by black ink. In contrast, the morphology of the condyloma shown in the right panel is completely different. First, notice that the basal layers, where most of the cell division is taking place, is much thicker. And secondly, notice that above this layer, instead of flattening out, the cells have expanded tremendously to form large balloon-like structures with prominent nuclei in the center. These cells are called koilocytes and are filled with HPV particles ready to be released when the cell breaks open on the surface. Now, these productive HPV infections that give rise to condylomas are quite common and generally regress in about 2 years and are not of a major concern. Now, I would like to consider the second possible event that can occur after HPV infection, which is shown on the right here. In some cases, the virus can incorporate its genome into that of the host cell, and this leads to aberrant growth of the cell that can eventually lead to cancer after a lag period of perhaps 10 to 30 years. There are 2 points that are important to note. First, not all strains of HPV lead to cervical cancer. And secondly, even if the HPV is incorporated into the host genome, this does not directly lead to cancer. Rather, it leads to a condition known as cervical intraepithelia neoplasia, or CIN for short, that represents a spectrum of benign or premalignant conditions. Now, CIN is a reversible condition. That is, it can go away on its own. CIN is classified into 3 grades, 1, 2, and 3, which show increasing amounts of dysplasia. Remember, the term dysplasia means that the cells are not quite histologically normal, but not quite malignant. In this case, the dysplasia refers to the abnormal differentiation of the cells as they migrate from the basal layer to the free surface. Now, this slide shows a normal cervical epithelium and the different grades of CIN. The key feature for determining the grade of CIN is the thickness of the layer of dividing cells at the base of the epithelium, indicated here by the white arrows. The panel on the far left shows a cervical epithelium that is normal except for the fact that it contains some koilocytic atypia due to a productive HPV infection. Observe that the basal cell layer, where most of the division takes place, is 1 to 3 layers thick and represents perhaps 1/10 of the thickness of the entire epithelium. The next panel shows CIN1, in which the dysplasia extends to the lower 1/3 of the epithelium. Next, in CIN2, the dysplasia extends to the lower 2/3 of the epithelium. And finally, in the panel on the far right, CIN3 is shown, in which the dysplasia extends through the entire width of the epithelium. The importance of this is that the different stages of CIN can be determined by examining a sample of cells from the free surface, in other words, a pap smear. This slide shows pap smears that indicate the progression from normal to CIN3. In the upper left panel, please note that the normal cells are large, flat, with very small condensed nuclei. Now, as the cells progress from CIN1 to CIN3, note that the cells become fatter, that the cytoplasm stains darker, and the nuclei become larger, and that they occupy a greater proportion of the cell volume. Remember that all CINs are considered to be benign conditions and are potentially reversible. Now, if a pap smear indicates the presence of CIN3, as shown on the right here, then that individual is at a much greater risk of developing cervical cancer. Another name for CIN3 is carcinoma in situ. Now, this is still considered to be a benign condition because the cells have not as yet made the final critical step of invading through the basement membrane. This figure shows cervical cells invading through the basement membrane. Again, this is the key event indicating that the epithelium has transformed from a benign to a malignant condition. It is important to emphasize that only a subset of HPVs can cause cervical cancer. This final slide shows how cervical cancer is staged. Now, staging depends upon the size of the primary tumor and the extent of spread and metastasis. On the far left, you can see that stage 0 consists of CIN3, or carcinoma in situ, that is confined to the transformation zone. This premalignant condition is easily treated by a cone biopsy that removes the suspect cells, and the 5-year survival rate is essentially 100%. However, as the tumor progresses from stage 1 to stage 4, the situation changes dramatically. The size of the primary tumor increases, and more of the normal surrounding tissues are invaded by tumor cells until at stage 4 it has metastasized to other organs. As you can see, the 5-year survival rate decreases significantly as a function of the stage. Treatment options for the latter stages include surgery, radiation, and chemotherapy. This concludes the introductory video on cervical cancer.